Okay, hello, and good morning. We're back. It's me again, Andrea Evans, Morecare's Marketing and Communications Coordinator. But for those of you who have just joined us after the introduction, welcome. I'm really excited to kick off the Harris Virtual Conference with my colleagues Beth and Dana from Morecare. So a quick reminder, when we're going throughout the presentation, if you do have a question, if your microphone is connected for this session, you may use the raise your hand feature, which is on your control panel, which is probably on the right side of your screen. Or of course, you can also type in a question under the question drop-down field on the control panel and ask those at any time. So I'm really pleased to introduce today's speakers. We have Beth Brand, Morecare's Vice President of Product and Customer Solutions. Beth has over 30 years of experience in the healthcare industry, which ranges from critical care nursing, clinical informatics, and decision support to product expertise. Prior to joining Morecare, Beth was a longtime customer of ours at Indiana University Health, where she was the Director of Clinical Decision Support for the health system. Her team is responsible for reporting quality and financial outcomes for clinical populations, physician services, and the health system as a whole. When it comes to reporting and leveraging data, this is Beth's niche. She is certainly a true expert. And since joining Morecare, we're really lucky because Beth continues to work with reporting, data analysis, and enjoys helping clients achieve better outcomes and successful results. We also have Dana Beaver Lewis, our Senior Clinical Solutions Consultant. And for over 30 years, Dana has led her career with care and compassion, immersing herself in helping others and organizations in the healthcare field. On the front line, Dana has worked as a quality utilization review coordinator for over 15 years before she made the leap to specializing in implementation. In 2004, she joined Morecare, and her combination of hands-on experience along with expertise in hospital quality peer review, care management, utilization review, risk management, and infection control are an added value when working with clients. Now that you've been introduced to our experts, I'd like to pass it over to Beth.
Okay, thank you so much, Andrea, and thank you to all of our participants today. As you guys just heard, Dana and I come from the hospital side, and we both know how busy you all are, especially right now, and how many hats you're probably wearing this week and in the weeks to come. Time is a very precious commodity, and we thank you for sharing your time with us. Our purpose in having this discussion today is to share with you some of the insights that we have gained through working with our customers as we've assisted them in establishing a measurement strategy so that they can determine the effectiveness of their care management programs. Our agenda today is as follows. We're going to start out talking about what it means to be data-driven. We're going to touch on reporting versus analysis, and then we're going to talk about leading versus lagging indicators, kind of demystify those. They're such buzzwords right now. We'll kind of talk about what those mean in the world of care management. And then actionable information, how to get that. And then at the end of the day, why is this important after all? Another important buzzword, ROI. How can this help care management demonstrate ROI? And then at the end, as Andrea said, we would love to have questions from those of you who are joining us today, and we'll do our very best to answer, and also, if not, to refer you to the appropriate people. So thank you guys very much for being with us. All right, let's jump in. What does it mean to be data-driven? Data-drivenness is about building tools, abilities, and most importantly, a culture that acts on data. And those of us who come from the healthcare setting and have had anything to do with process improvement, we're all very familiar with Dr. Deming and his groundbreaking work. And I love his quotes, and this is one of my favorites. Without data, you're just another person with an opinion. And isn't that the truth? How many times do we have conversations and everyone has an idea as to what's causing something or why something isn't working? And at the end of the day, show me the data. So the prerequisites for a data-driven organization start with, first of all, data collection. This might sound simple, but in many organizations, it's not so simple, because what we want is not just any data, it must be the right data. It must be relevant to the questions you're trying to answer, to the problems you're trying to solve. It can't be subjective opinions. It must be timely, accurate. It has to be unbiased and concrete, right? Also, data availability is incredibly important. We have to be able to join our data with other data within the organization when that's appropriate. Shareability. What that means is that, when data is available to more parts of the system, the whole is greater than the sum of the parts. We have to move away from siloed data. And then our data must be queryable. We must be able to slice and dice the data. We must be able to see trends or understand differences among patient populations or segments. And then we need to move from reporting into analysis. Now, don't get me wrong, reporting and alerting are very necessary, but by themselves, they're not sufficient characteristics of being a data-driven organization. We can't understate the importance of reporting, but reporting is a highly valuable component of a data-driven organization, and you can't have an effective organization without it. However, there are many organizations that focus on reporting and may have little to no real objective analysis. Reporting tells us what happened in the past. It's like a report card. But analysis tells us why it happened. It's prescriptive. It's diagnostic. But at the end of the day, that's not all. Data alone is not going to transform your organization. One of the shortcomings in today's movement to big data is that all of that data alone can't be useful without subject matter experts who can discern and use the data elements in the right context. There need to be humans in the loop. Humans are the ones who can ask the right questions, who have the skills to extract the data and the metrics, and most importantly, can use that data to actually inform next steps and make change. So let's talk a little bit about leading and lagging indicators. As I said, these are kind of the current buzzwords, but at the end of the day, it comes down to process versus outcomes. So leading indicators, these are our process measures. These are the drivers to your outcome. This is how you are going to achieve your outcomes. You have all put processes in place, hoping that at the end of the day, if those processes are followed, that outcomes will be improved. So these measures are measuring the things that you do, and they help you anticipate and predict what will happen. Lagging indicators, on the other hand, this is what we're all used to. These are the outcomes measured. These are scores, metrics that are used all day, every day to demonstrate the performance of the organization. So what outcomes measures do is they measure the results of the work you have just done. So again, leading indicators are those that you can influence and control through changing your processes. They help to influence or impact what the lagging indicators or the outcomes will be. Outcomes measures are usually much easier to identify and measure. Actually, most of us are living with these every day. So these are the measures that are used to demonstrate quality and value in healthcare organizations. And over the past few years and decade, these measures have just exploded. I think if anything, you all are inundated with the latest quality scores, the latest, how you're performing against a benchmark, et cetera. You also probably all have measures that are included in your organizational goals. Some of the examples that are very common for healthcare organizations are length of stay, readmission rates, returns to the ED, mortality rates, safety events, et cetera, et cetera. All of these are outcomes measures. Process measures, on the other hand, are often trickier to develop. So in order to come up with appropriate process measures so that you know whether your care management organization is performing according to plan, you need to start by asking what is your plan? How do you plan to impact those outcome measures? What are the key steps that you have built into your process that you expect your staff to be following? An essential component of process measures is that you should be able to influence them. If something isn't working, you should be able to change it, right? Those are your processes. So if we look at a very generic process diagram here, what we'll see is that, pardon me, for any process, there are usually different phases, right? And within each phase of the process, there are interventions or activities that you have outlined that need to occur. And if all of these things occur as planned, then we would achieve the outcome that we hope to achieve. Now let's talk about how we can apply this concept to care management. Well, again, the outcomes or the lagging indicators over here on the right, these are the easy ones, right? These are the ones that you are all familiar with: length of stay, readmissions, observation length of stay, denied denied stays, both inpatient and observation, your medical necessity denials, et cetera, et cetera. These are things that you all are working towards every single day and monitoring, watching, and so is your organization. The leading indicators are the processes that you all have put into place to try to impact those. So for instance, you have discharge plans being initiated on the first day of stay in a hope to move that discharge along in a more timely manner and decrease your length of stay. You have readmission risk assessments that you're completing on all patients, trying to be ahead of the game to identify and understand what are potential risks for readmission so that you can decrease those. Our observation patients being seen in a timely manner. Many of our customers right now are really focusing in on observation patients and have put into place some very specific processes. And then it's important to see, are we following these? Are these processes working? Are patients being placed in the appropriate status initially, which would help with our denials? Are physician advisors responding in a timely manner, and are they responding appropriately? Our post-acute provider partners responding to referrals in a timely manner. This is so important as we try to manage those relationships with those post-acute partners. We want them to be, if they delay in getting back to us, if we can't get responses and determine where these patients are going, it can really impact our length of stay. It can also impact the handoffs and can lead to potentially readmissions and denials. And then what avoidable delays are occurring? This is another thing that oftentimes, and we all have been in these situations where you're in the day-to-day and you're putting out the fires every day, and intuitively that there are some issues and there are ways that your system could be more efficient, but it isn't until you start to track it and actually then quantify and look back over a period of time, a week, a month, that you begin to see, oh my goodness, look how many times this is happening. If we could remove this barrier, think of how we could impact potentially our length of stay or our denials. So you see, it's not mysterious. There's no magic here. It's just start with your processes. Are your care management interventions and activities occurring as planned? And if so, are the outcomes where you want them to be? Is your program resulting in meaningful changes in your outcomes? And then if not, does the process need to be changed? Are your interventions yielding their intended results? And if not, then we need to probably change those, right? But it's not until you begin to measure and to look and to study that you become aware of that. All right, so we're going to take that same diagram and let's look at an example. Let's look at an inpatient stay. And the care management process that's been built around that. So the first phase of the stay is admission. And the care management, many care management processes involve an initial review on the first day of stay, that involve readmission risk assessments being completed. And the question is, are these being done? The next phase is at the actual during the stay. Are we doing our discharge planning as outlined? Are there any delays in service? And if so, are these being tracked? Then as we prepare for discharge, are we making timely referrals for the post-acute services that our patients need? So are we reaching out early enough in the stay or so that we don't have a delay at the very end on the very last day? And are we getting timely responses back from our post-acute providers? And then after discharge, many of our customers are performing post-discharge calls to follow up with the patient and find out how things are going, if there are any questions, if there's any confusion, any barriers to getting their medications or to getting their follow-up appointments. And if all of these things are being done and followed as we have outlined, then our anticipated outcomes are that we will see a decrease in length of stay and a decrease in readmissions. And at the end of the day, what we need to understand as we manage these processes is, are all the steps being completed according to design? If not, then we need to focus on those gaps, and we need to put some time and attention to making sure that everyone understands the process and begins to follow it. But if the process is being followed and we feel that everyone is doing what we've outlined and our outcomes are still not moving, well then it's probably time to take a very critical look back at our process and see what might need to be changed. But it's only through the analysis of the process that we can move forward in a meaningful and purposeful manner versus just working on anecdotal information and subjective opinion. So it all boils down to a measurement strategy. And for any care management program, developing a measurement strategy is essential to demonstrating value. A successful measurement strategy allows you to not only evaluate whether your program is successful, to identify where you might need to improve, and to help you as you meet your outcomes goals, but, and this can't be stressed enough, a good measurement strategy helps you demonstrate to your organization the value that you're providing and build support for your program within your organization. And this is where we get to the ROI. We've all heard the term ROI, return on investment. And traditionally, we think of an return on investment as referring to how much money we're making on an investment or a technology. However, an equally important question is what else can be done to reduce costs, improve care, and maximize resources? So we know that care management is not a revenue generating department, and yet it is so essential in minimizing costs and making sure that our resources and our time are being spent appropriately and that our patients are utilizing our resources in the most efficient manner. So it's through decreasing cost that we can really truly provide demonstration of value to our organization. And later on today, we're going to show you after we've shown you some examples of information, we're going to also take you through a quick exercise in demonstrating ROI. All right. We're now going to show you some examples of some reporting that we have done with some of our customers here at MoreCare. And as I said before, reports are very important along with analytics. So this is an example of how one of our customers was very, very tuned into the observation process. And that customer has set up some very specific milestones in their review process. They want to make sure that their observation patients are being reviewed and that they're being reviewed in a very timely manner. And so what is important to them is to look at the different time periods. So you'll see here moving across, this is a monthly view, right? And every month they are looking to see how many of their observation patients are not being reviewed at all. This dark blue bar here says how many are being reviewed within 12 hours, which is their goal. That's what they want. That's what they want for everyone. How many are having their initial review done within 24 hours or within 36 hours or greater than 36. And then across the top, we see a trend line showing the total volume of observation patients that were registered during each of these time periods. So obviously, as a manager or director of the program, what I want to do is I want to see this dark blue bar. This is my goal. And I want to see this increasing. And I want to see these other bars decreasing because I want really to know that all of the patients are being seen in the time frame that we had outlined. And yet the question would be, why is this going down? Why it's, we're slipping in our process. So we don't have any higher of a volume here this month than we had this month, and yet the percent that were reviewed and the time frame that we had identified has decreased. So this gives me something to work with. I can dig into this. I can understand more about the patients who did not get reviewed in a timely manner. Likewise, we have another customer who is very focused on their admission reviews for medical necessity. They've had some issues in that area, and so what they wanted to know, they are an organization with multiple hospitals, and what they want to know is their leadership wants to be able to look at a hospital level within the organization, and they want to be able to see how many of the inpatient admission reviews were scheduled, and how many of those were completed, how many were completed within 24 hours, which is their standard, what percent were completed, and what percent were completed within 24 hours. And then this is on a monthly basis. So they can also compare their different hospitals, look across the organization and see where they have their high performers and where they have the need for some improvement. Now we all know, I can't stress this enough. We all know that there are, in many cases, there are reasons behind some of these variances. It could be that one hospital does not have weekend case management, right? Or there could be multiple reasons, but it's important to at least begin this first step and to begin to look into this. And this is now directing the focus, right? As a leadership person in this organization, I don't really need to focus here. I need to focus here, right? Why is this organization struggling to complete their reviews in a timely manner? We also talked about the importance earlier of managing those relationships with our post-acute partners. And this is an example. Now, I know all of you in the hospital setting, you're very used to looking at discharge dispositions and where your populations are going after they leave the acute care setting. So this is something that I know is readily available to many of you. So we understand the percent or the number of our patients who go to a skilled nursing facility versus rehab, et cetera, et cetera. But what we want to do is we want to dig a little deeper into this, and we want to look at those patients who are going to a skilled nursing facility. We want to drill into that. And as we do that, we uncover some information here which can direct our actions. I see here the various nursing homes that my patients are going to. I also see their CMS star rating. That's one of the attributes of our More Care solution. But I'm able to see the number of patients that each of these facilities accepted. So my attention is immediately drawn to this Oak Bridge facility. They're accepting a large number of our patients, and yet the average turnaround time in hours for those referrals is quite high. It's much higher than the goal that we have established as an organization, which was 5 hours. It's taking them almost 10 hours on average to get back to me about placing a patient. Well, think about it. There's a day, that could be a day in the length of stay. So this allows me now, this arms me to go and have some very focused conversations with this particular partner. Likewise, I have two facilities here who are demonstrating a higher than desired rate of readmission back into my hospital. I had a goal established here of 15% or less, hopefully, and yet I have two specific partners here who are not meeting that goal. This, again, this is actionable information. I need to have some very specific discussions. Our handoff process is not adequate. You know, are there gaps in that? Is there additional information that is needed? How can we ensure a more successful transition to the post-acute phase of care? Okay. At this point right now, we're going to ask each of our attendees to do a tiny bit of work. Okay, we have a poll here. We want to ask you to please answer the poll. You should be seeing that on your screen right now. I hope that you are. And if you could please answer the question. There we go. I see that the answers are coming in. We'll give this a few more seconds. Okay. If you guys could just take a second and just answer that one question. That's all we're going to ask you. It's not a trick. It won't lead to a longer questionnaire, I promise. Okay, it looks like about half of our people. If we could have just a couple more people click and give us this information, we would really appreciate it. All right, so it's looking like about half of the people attending are currently using dashboards and analytics. We have quite a few who are not, and many who are also considering those in the future. That's great to know. So thank you guys very much for taking this time to answer our question. And now, at this point, we're going to go to one of my most favorite parts of the presentation, and Ms. Dana Beaver-Lewis is going to take you through a demonstration of our analytics and dashboards. And as I just want to emphasize, reporting is very important. We don't want to underestimate the importance of looking at reports and understanding metrics. But what enables us to really understand where those processes need to be improved and where we need to take action is this movement into analytics. All right, Dana, I'm going to turn this over to you.
Okay, thank you so much. And let me make myself the presenter. And if you could let me know if
Yes.
once you see my screen.
Yep, we see it. Thank you.
Okay, great. Thank you. Thank you again, everyone, for joining us today. So what I'm going to review with you is our More Care Analytics dashboards. And as you can see here, we have quite a few dashboards. We're creating more, so we'll have one for each one of our modules. And our dashboards are really nice because you are able to see how your processes are going. You know, what happened on the surface, and then you can drill down to find out why did it happen. And then you can change processes if need be. Okay, so today we're going to focus on the one for case management, the one. So I'm going to already have that open. So I'm going to click here. And now we can see the dashboard. So just off the bat, we have 6 different reports or quadrants here that you can see. Over here to the left, I can choose if I'm part of a multi-facility, and in my role right now, I'm going to pretend that I am, but I can just drill down or just see just one facility, or I can view all my facilities, all the data that's coming in from all of my hospitals. I can also modify my date here if I wanted to look at maybe just 1 month, or if I wanted to look at more than 1 month, or then at this point I'm looking at 6 months. Okay, so we allow you to be able to do that so you can really get the information that you want to be able to see. So right here, we're going to talk about, let's just see how our volumes are going here. I can see year to date for how many inpatients we had, observation, the average length of stay for my inpatients, and the average length of stay for my ops, and then last year compared to that, which is nice. So I can see that we got pretty good. So we have decreased a little bit of our length of stay for our ops and our inpatient, but it's nice to be able to see the volumes, you know, how many people are coming into our hospital and how many observations are coming into our hospital and how well we're doing with that. Over here on the right-hand side, we can see patient status changes. And I'm going to keep modifying my screen a little bit just so you can really zero in so you can see the information here. So within our dashboards, we allow you to deselect several areas. You can really, again, drill down at what you want to be able to see. So I'm going to take away these areas here just for a second. And this is showing me that how well we're doing with assigning our patients in the right status the first time. Okay, so I can see we're doing pretty good. A patient is admitted as an inpatient, they're admitted as an ops, they're supposed to be in that particular status, which is great. I know when I used to do utilization, that was a big thing. We always had to kind of double check to make sure the patient was in the correct status. And one of the things that we put in place was a little assessment. So every time a patient came in, we would do an assessment to just double check, was there an order for admission? Does the patient meet criteria for admission, or should they be in ops? And I can see that the fruits of my labor are coming out really well here. We're doing pretty good with making sure that the status that the patient is in is a status that they should have been in. They're staying in that status. And now I'm going to deselect these and I'm going to look at just the ones where we did have a status change. So this is where I can see when the patient went from an ops to an inpatient, which is pretty good. Again, I have my case managers are out there and we're really reviewing things and we're making those changes. But the one that is a little disconcerting is when we have an inpatient that then goes to ops. So with all of these different areas here, I can then drill down to find out, how are things, are we not identifying these, well enough? Are there certain doctors that are not putting the patient in the right status, or are we missing some of those as far as our case managers go? But overall, as a manager, this looks really well. We're doing a great job here. So don't need to drill down here. It's looking great. So now I'm going to go down to this next quadrant here, which is looking at my length of stay for my Medicare patients versus all my patients. So once again, I'm going to deselect a couple of these things so we can really look at this information. So I want to look at, I think I'm going to take my Medicare and my non-Medicare to see, okay, what are the length of stays? And this is telling me some information, but it's like, okay, it's not, really can't tell anything with this at all. However, when I pull in my threshold, then I can see how well are we doing compared to my organization's threshold. And when I go here, I can see the overall threshold. We're doing pretty good. It's not too bad at all. Okay. And then when I go to my Medicare and pull that up, my Medicare threshold, I can see that we're not doing very well. Okay. So this is really something I want to be able to look at and be able to drill down to find out why aren't we doing these items, or why aren't we meeting our length of stay for these particular patients. Okay, so I could drill down on these, and I think I am going to go ahead and drill down on one of these. So I'm going to drill down on my Medicare one for April, and let's see. So when I drill down, it's going to open up my next area. Okay, we'll give that just a minute. Okay, and I'm going to make this a little bit smaller so you can see it completely on the screen here. Okay, so I can see here for April, see the average length of stay overall, average length of stay for my Medicare and my non-Medicare patients. So I'm going to click on Medicare here and let this open up, and I can see overall, whoops, how my hospitals are doing. Let's see if I can get that to stay. How my hospitals are doing. And I really want to now look at Oak Park Hospital and see how they are doing with their length of stay, and if there's a process I can put into place to make a change to that. So this is opening up my financial classes here. Okay, and I'm going to click on this financial class here, and I'm going to make this a little bit smaller. And what this is now allowing me to see, let me move this in a little bit here, is that I can see for these particular patients, I can see that the length of stay is pretty high, but when I scroll over, let me make this a little bit smaller here. Okay, that I can see that most of these patients are in rehab and in the psych unit. And this is something I would want to pull out of my reporting. Okay, I just want to look at the acute one. So this allows me to see, what happened, why we had a discrepancy between what we want in our threshold, and then I can see why this is happening. So now I know when I redo my processes, or redo this dashboard, I want to pull these units out of here so I'm looking at the right information and being able to make an informed decision. Okay, so now let me close this out. Okay, all right, open this up again. Okay, so the next area I'm going to talk about is over here to the right. We're going to look at the admission productivity for my hospitals that I'm responsible for. And one of the processes that we put in place, of course, is I want my staff to do reviews within 24 hours, their admission reviews. And I can look here right off the bat and see how my hospitals are doing. And when I mouse over, I can see the percentage. And I see More Care Hospital is doing very well. They're getting their reviews completed within 24 hours. Was at 95%, a little over 95%. And doing their overall, they're getting them completed within 99% exactly. But the one I want to look at here is the Oak Park Hospital. Oak Park Hospital isn't doing too well, and neither is Hyde Park Hospital. Okay, so I'm gonna click on Oak Park Hospital to see what is going on with them. You know, is their caseload too high? Why aren't they getting these things done in time? And this is giving me a nice drill down here so I can see for each one of my reviewers, how many admissions were scheduled for them, the number that were done where they answered a questionnaire and assessment or internet comment, the number completed within 24 hours, completed within 24 to 48 hours, greater than 48 hours, the ones they haven't done yet, and the overall percentage. And I can see here, are there any discrepancies or anything that I could do to make a difference to help them complete these reviews within 24 hours? And I can look here, this caseload for this reviewer is a little high. So maybe I can move some things around a little bit so that she is able to help us meet our initial goal. So again, looking at from a high level view, why is this happening? What happened? And also I can see why it's happening. So now I can make changes in my process in the caseload for my staff. Okay, that's the thing I love about dashboards, that it puts both of those items together. You can look at it holistically on a high level and then drill down if need be. Going down here to the bottom, here's our delay types. And this is an area that Beth talks about. This is one of my leading indicators. Okay, of course, we don't want delays, but delays happen. This is showing me overall for my delay types, how many delay types were attributed to physicians, to an overall service, was external, which means it might be due to a nursing home not having a bed, or family can't take the patient home, or is it ancillary? So I'm going to click on the physician-related delays, which is 30% of my overall delays. And now it's going to drill me down to the next area. And I can see what's going on. Why are these, what areas are the physicians failing at when they're with these delays that we're looking at? And I can see here consultations, of course, it should be done within 24 hours. Lack of discharge orders or documentation, of course, this could affect my length of stay and also cause us to have denials as well. So again, I'm going to drill down and see if there is any type of pattern here, where I can see if there's a certain physician, where I can then have a lunch and learn with that physician to try to help him get these processes done within an appropriate amount of time so we don't have these delays. So here I can see that we got Dr. Barnes. He has a little bit of an issue here. So I can see the patient's name and counter. So now I can take this information and just go a little bit deeper with it and begin to look for patterns, and again, talk to the doctors if I need to. Again, change my processes if it doesn't seem to be falling within the appropriate thresholds. Okay. All right, so in the middle here, we have our UR metrics and our observation metrics. And this area here allows me to see what type of reviews are being done. And I can see admission reviews, we have continuous stay reviews, observation, and here's the post-discharge reviews. And Beth mentioned that as well. This is something we put into place to decrease our, possibly could decrease our readmissions. And I can drill down into these to see all the different staff that are doing their post-discharge review, if they're doing appropriately. But the fact that I see these numbers are up here, I can tell we're doing exactly what we're supposed to be doing. So I should still see a steady decline in our readmissions because we did initiate that initial process. Now for observations. So here we can see the total number of observations that we had, total discharges, the total ops that are Medicare, for other payers. And then we have ops that stayed within 24 hours, which is fine. Ops that stays between 25 and 48 hours, and then ops greater than 48 hours. And this is an issue here. So my initial thought, did we miss an opportunity to convert these patients from an ops to an inpatient? Should they have been an inpatient? So now I'm going to look for some patterns. So this is showing me again what happened. Let's see if we can identify why it happened. So I'm going to go ahead and click on we'll click on February here, and it's going to drill me down to my next area where I can see where is this happening at. Mainly in Med-Surg, we have 20 here. So I'm going to click on Med-Surg, and again, trying to look for a pattern. What process can we put in place to change this? And I can see, okay, here are my physicians. Now, one of the things that you can do with all of our dashboards and all of our individual drill down reports is you can export it. So this is one that I'll actually want to export to Excel because I want to see if I'm going to put it in order by physician. And I might even want to take this to our medical director and say, we need to talk to these physicians. They seem to be some of the same ones that are bringing these patients in, and they are not, okay, let me hit editing here, and they're not in the right setting, or they're keeping them too long. So here I can click on attending physician here, and I'm gonna do a sort. And again, just try to see if there's a pattern here. And I can see that there is. I can see that this physician here has quite a few, this physician here. So now I can actually see the length of stay hours, the physicians, and I can take this report again and talk to the physicians and determine why is this happening in this area. And also, one of the things you can do with our dashboard is that you can look at more than one screen at a time. So I can see here, okay, well, MedSurg seems to have an issue here, but I'm gonna go back here. Now I wanna look at one more. I'm gonna open this one up, and I wanna look and see for, not February, I wanna look at one more. Let's see if I can go back here. Okay, I'm gonna look at January. And see, is it that unit? Maybe that unit has an issue. And sure enough, MedSurg, there's 18 here in January. And in February, there were 20. So I can review as many of these reports as I want within one dashboard, which is great. And again, I can drill down and look for a pattern for that particular MedSurg area and see if there's a change I can put in place, or speak to my physicians to get our ops number down, and I should be seeing a decrease. And you can see, based on my processes I put in place, it went down in June. We only had 13%. So as you can see, this is a great tool to measure the effectiveness of your overall performance and your process towards achieving these various goals that you might have in your organization. Okay. All right, so Beth, that's all I have for this. So I'm going to turn it back over to you, and we are going to take some questions.
Okay, great. Thank you so much, Dana.
Mm-hmm.
Let me take this back.
Mm-hmm.
Wow, thank you, Beth and Dana. That was very insightful. And I know for myself, I find it really impactful when I see how data-driven decision support can really help cut through those complexities and allow you to engage with interactive and actionable data right at your fingertips. So that was great.
And yeah, we do have a couple of questions here. Did you want me to go through them, Andrea?
Yeah, absolutely. And just this is a quick reminder as well for anybody, if you do have a question, you can use the raise your hand feature and we can unmute you, or you can use the use the question function on the control menu. It's a drop down, and type in your questions.
Okay.
But I think I'll turn it back over to Beth, and she can talk a bit more about some of the hallmarks of data-driven organizations, and we'll get to those questions in maybe just a minute.
Okay, sounds great.
Okay, thank you guys, and thanks so much, Dana. I swear every time you go through that, I learn more. And of course, I am an admitted data geek, so I absolutely love and find the dashboards fascinating. Well, just to kind of bring this all back around full circle, one of the things that we've been talking today about being a data-driven organization. And what's very important is that data-driven organizations make decisions using a variety of metrics. And I hope we've helped with that. Something that's very important is continuous measurement. We have to always be measuring and looking at those metrics, but also a constant improvement mindset. And this is where you have to put on that detective hat. You constantly have to be wanting to understand where improvements could be made. Where are we not quite where we need to be? Constantly digging. But then at the end of the day, and there's a funny saying that people use about being willing to say that your baby's ugly. You have to be open to updating and refining your processes. So if the data's pointing you there, if all roads are leading to this conclusion, then you, at the end of the the day, you've got to be open to the fact that things need to be changed. We need to just tweak our processes. And the question to ask for all of you is your organization forward-looking, and are you treating data as a first-class citizen? Oops, sorry, I just went past a slide here. Hang on. There we go. And as we've said, the bottom line is that tracking both process and outcomes measures is essential to understanding what's going on in your organization and to knowing what changes you need to make in order to improve those outcomes. All right, now we talked earlier about an ROI, and we at MoreCare have an algorithm, a tool that we use with our customers to help them understand how making small improvements in their outcomes could really lead to some significant cost savings for their organizations. So I'm going to take you through this as an example hospital. I've taken the liberty of using some very generic averages from across the country as we go through this, but we're going to just show you how to apply some of these metrics to determine an ROI. So we're going to start with some key hospital metrics, which are your total discharges per year. And for this example, this is just an example hospital. We're assuming you have about 7,500 inpatient discharges in a given year. Obviously, organizations fall anywhere along the spectrum. But for this example, this is what we're using. We're also assuming that your organization has about a 35% Medicare population. Again, yours could be higher or lower, but this is a pretty safe assumption. And we're going to deal in this example just with our Medicare discharges because we are going to be looking at how to decrease length of stay or rather how a decrease in length of stay can save us money. Well, as we know, our payment right now, we have fee for service, we have the DRG fixed payments, and at this point in time, what we're going to focus in are those Medicare discharges, which are primarily DRG payments, meaning that we receive one sum of money regardless of how long we keep that patient in the hospital. So we're going to focus on our Medicare patients, and this is where I use some national averages right now. Across the country, on average, approximately 21% of the patients who are being discharged from acute care currently are being placed in skilled nursing facilities. Approximately 23% of patients needing home health care who are being discharged are requiring home health care services. And then approximately 56% of patients are leaving acute hospitalization stays and are not being placed with either service. Again, these are averages, but when we apply these averages to our make-believe Medicare discharges here, you can see that these are the numbers impacted by each of these discharge dispositions. Okay? Next step then is we're going to say, let's say that we've put some processes in place. Let's say that we are automating our care management program and we're very happy to have an automated standardized process. We're instituting some assessments at some key times, and we have what we feel is a really good process, and we're going to be managing that process. And what we hope to do is decrease length of stay. And our goal is that for those patients going to skilled facility placements, we're going to decrease length of stay by half of a day. Again, I'm being conservative here, so we're not trying to be, we're not trying to go way out there. We're just trying to be conservative. And let's just say that our processes are going to help us decrease the length of stay for patients going home with home health by a quarter of a day. And that our discharge home without services, we're just going to be super conservative and say a 1/10 of a day overall an average length of stay. These are pretty conservative, right? Now, if we apply these, the next thing is we're going to say that our hospital, at our hospital, we have an average length of stay right now of 4.5 days. And we're going to say, just for the purpose of illustration, that applies to all of our patients. So the patients who are going to skilled nursing or home health also have an average length of stay of 4.5 days. And we're also using an estimated cost per day. These are not charges, these are not payments, but this is the cost to deliver the care, is $2,300 per day. This is a very conservative estimate, and I use the Kaiser Family Foundation for this example. Actually, in reality, what you'll find is published cost of care per day can actually be higher than this, but again, we're trying to be very conservative here. So on average, for an acute care hospital stay, it's costing the hospital in resources and time approximately $2,300 per day. And let me just say, those of you who have a cost accounting system, and I know we're going to be hearing from our Harris partners here right after this about decision support and cost accounting, something that's very near and dear to my heart. I love cost accounting. I told you I was a geek. That they will help you determine an actual cost of care for your organization. But for right now, we'll just use a pretty safe national average. So if we are able to decrease our length of stay as we have projected, and we assume that this is our cost per day, and we apply that to these populations here, what we see is those savings for skilled facility placements. We had 551 Medicare patients who went to a skilled facility. We were going to decrease their length of stay by half a day, which would allow us to save 276 days for this population, and we take that and multiply it by the cost per day, we could be saving our organization over 633,000. Likewise, for our home health services, we take those 604 Medicare patients who are going home with home health, and we apply, we are going to save just a quarter of a day. We're just going to shave off a quarter of a day over the year. We feel that we'll be saving 151 days and recognizing a savings to our organization of 347,000 plus. And likewise, our patients home without any services, you see how even just shaving off a tiny amount, little by little, if we can get these averages down, you'll see how we can recognize this saving. And at the end of the day, look at the savings that could be realized. And this is a pretty conservative estimate, and it's only looking at length of stay. Obviously, there are other areas. Think about readmissions. Not only are we saving costs, but we're alleviating or avoiding penalties. So it can really kind of go on and on, but this is an example that we wanted to show you. Now, what we would like to do is work with you guys if you're interested in pursuing, further conversation about one of our solutions. We're happy to use your own real hospital metrics and apply this algorithm and come up with a projected cost savings that would be more specific to your organization. All right, now we're at the point where we can answer questions. And so Andrea, I will turn it over to you.
Thanks, Beth. Great job. So thank you for your patience. We did have 2 questions come in a little earlier. Again, just a quick reminder, we would love to hear from you. If you do have questions, now is your time. Use the control panel and type those into us. So the first question we have for you, Beth or Dana, is that you mentioned the importance of being able to analyze and change our workflow processes as needed. My experience has been that anytime we want to change a process or a flow sheet, it requires that we get the vendor involved, and that can take time and money. Is that the case with your MoreCare application?
Oh, I'll take that one. Not at all. That's one of the great things about MoreCare, is that you are the driver of your processes as well as modifying the system to meet those processes. So if there's a new standard that's out there, you can go out there, you can create a standard or question and answer yourself. You can make certain fields required if you need to be required. You don't have to get us involved, but we're always there to answer any questions if you're having any trouble doing it. But that is a beautiful thing about it, is that it's totally up to, we put the power to the organization to make those changes as need be, and they do not have to get us involved unless they just want some help.
Okay, great. Thanks, Dana. And then our second question is, in your experience working with care management teams, what have you found to be the biggest issue when outcomes aren't improving?
Well, I'll take that one. It's funny, it really comes down usually to kind of a double layered answer there. The first answer usually really is, once you start to measure those processes and whether or not they're being followed, it's amazing how many times we find that they aren't. That key process steps are being skipped, are being, avoided. And really what it often comes down to is one of 2 root causes for that. Number one, there's been significant staff turnover, and perhaps it's kind of like that game of telephone. If you don't don't have continuous staff education and showing new people how to use the tool and showing people what the process is and why it's important, then over time it starts to degrade, right? So all processes take continued vigilance. But another root cause is that there might be really valid reasons why staff are skipping steps in the process that you thought was perfect. And so listening and understanding, why does this not work in the real life and the fires that we're fighting in the day-to-day out there on the front line? There might be reasons why one of those steps just doesn't work. And great idea, but we can't apply it in real life. And so that's when we work with customers to, help them refine, trim down, make their processes faster, more efficient. And oftentimes, like years ago when you take people from a paper or a manual process into an automated process, Dana pointed out how the customer has the ability to really define that process as they want. And sometimes those can get a little over-engineered. We can be a little overzealous in all the different pieces and components we want to collect. And then as time goes on and our staff utilizes the tool and actually tries to implement that process, that's when you start to find what does and doesn't work. So, and we have that happen quite a bit. It's almost like a natural life cycle, that then it's like time to go back, circle back and say, okay, we thought this was a great idea. Let's trim it down. Let's make it more streamlined. So that'd be my off the top of my head answer.
That's a pretty good answer. Okay, so I don't see any more questions here listed, but of course you guys are always more than welcome to get in touch with us. Please connect with us. We want to hear from you. On your screen right now, you will find Beth's contact information, bbrand@harriscomputer.com. We also have our upcoming webinar with industry expert Tony Sesta. She's going to be speaking about best practice roles, models, and staffing ratios for acute care, RN, and social work case managers. That's going to be coming up on Thursday, April 30th, and you'll see a registration link there as well. Also, speaking of social work, happy Social Workers Month to any that may be joining us today. Thank you for all that you do. So that concludes our presentation for today with More Care, Session 1 in the books. We'll let you guys grab some water, top up your coffees, and we really hope to see you at our next session, which is going to be in about 20 minutes from now at 12:15 Eastern Time. You're going to be hearing from our friends Simon and William, who are at Harris Affinity Decision Support, and they're going to be discussing the importance of making informed, timely decisions. So again, thank you everybody so much for joining us this morning. Stay on the line, hang tight, and we'll see you back soon. And Dana and Beth, thank you so much for being with us today.
Thanks,
okay.
Andrea. Thank you,
Thanks,
everybody.
everyone. Chat soon.
Bye.